And our next speaker is Anna Kiger. She's a Chief Nurse Officer and Vice President of Patient Care Services for Tenet Healthcare in Dallas, Texas, an investor-owned healthcare company. She's accountable for professional nursing leadership, clinical nursing practice, education, and nursing research for the entire system. Before she came to Tenet, she was an Associate Vice President for Nursing at Tulane University Hospital and Clinics in New Orleans. And there she was responsible for a nursing staff of over 650 people. In the meantime, she gathered many degrees. She has a doctor in nursing practitioner. She has a doctor in science. She has an MS in nursing. She has an MBA, and she's a registered nurse.
Well, I am delighted to be here today, and I was going to steal this time on the podium for sure because this is the first time I've been invited here, and I want to thank the Academy for the opportunity to be here today. But I have been an absolute sponge in this room today, and I am taking away a tremendous amount of information for an organization the size of mine. And I'd just like to tell you a few things about the presentation and our organization. Just a quick overview of our healthcare company. I have a focus on women and children's in the company. I actually have FTEs that do nothing for me but direct the clinical excellence practice around women and children's services. We have a huge support internally across our investor-owned company to support breastfeeding for all of the reasons you mentioned in the room today: nutrition, obesity, healthy children, children who avoid future health care expenses that are truly preventative and not warranted in some cases. I think there are a tremendous amount of stakeholder interest in this topic. The managed care companies in the room are actually a great partner with me back at our investor-owned company, and I work closely with them, and I'm going to talk about that very briefly. And then just to give you from my perspective as a system chief nurse officer over a very large corporation, what my future direction for our company is in women's and children's, but specifically in supporting what you all want to achieve, which is breastfeeding for children in America. To give you a little bit of idea about Tenet Healthcare, we have 110 employees. I oversee the operations for all clinical services on our 80 acute care hospitals. We operate in 43 states. We actually own hospitals in 14 of those states. We reported in 2014 at $16.6 billion of revenue, and we are rated at 183 on the Fortune 500. I oversee the practice and the patients who are in 20,000 beds every day in our hospitals. I look at the operations in our perioperative, and we perform over 168,000 surgical procedures. We delivered 102,000 healthy babies last year in our 14 hospitals. We have 20 million patient encounters across this acute care and some ambulatory operations that we own, and we are at risk and manage 5.2 million lives. Yesterday, this slide is now outdated. Yesterday afternoon, we closed an acquisition in the United States and acquired USPI, the largest owner of ambulatory surgical centers in the United States and globally. So now I have inherited, since I went to bed last night, about 200 ambulatory surgery centers in the United States and in England. And in that acquisition was an additional 12 acute care hospitals, 8 here in the United States and 3 in England. So the slide was prepped last week and it is outdated already. And that gives you an idea of mergers and acquisitions, which happens to be my area of expertise in healthcare executive leadership. So give you an idea of the geography of our company. Healthcare is very locally driven and given, and I oversee those states where you see the blue dots where we have the acute care hospitals. We have grown, as I just said, into this very large corporation in the last 2 years. We've been around since 1995, but we've grown tremendously in the last 24 months. We acquired a 29 hospital system just about 18 months ago, and we have now stood up 16 ACOs across the United States. So our footprint is becoming bigger, and as you can imagine, out of the 80 hospitals, about 60 of them operate a labor and delivery unit and deliver anywhere from 50 babies a month in some of our rural operations to 450 or 500 a month in some of our hospitals. So in my area of responsibility for the company, where I oversee all nursing leadership and clinical practice in those hospitals, we have always had a focus on women and children. But in 2005, we took a serious look at population health risk management, medical economics, a lot of what you've heard about today, and we committed as a company to stand up an official perinatal safety and women and children's services. At that time, we were able to attract, and she's still with us today, a director of Perinatal Services who, in my mind, has developed one of the finest women and children's clinical service programs and perinatal safety programs in the United States today. One of the things that we've done in 2014 in recognizing our footprint was becoming larger, and also to begin managing some of those covered lives, those risk lives, and that 5.2 million was to add a manager of perinatal. So now I have master's degreed nurses who can go from labor and delivery to neonatal, PICU, NICU, and adolescents. One of the programs that we cut our teeth on to bring the benefit value home and the business case home, we implemented that all of our registered nurses working in our labor and delivery departments within 90 days of employment would complete the initial A1 certification program for correctly interpreting a fetal heart monitoring strip. We also approached our practicing obstetric physicians to acquire that initial and intermediate or advanced certification, and went as far as to work with them and their risk insurance carrier to get a 5% reduction in their medical malpractice insurance premium if they participated in our program. We've been 100% successful in getting our nurses to complete initial and intermediate A1 certification. We've been marginally successful in getting the physicians to take us on because they just don't find time to come to class, they don't want to speak the same language as nurses about interpreting the fetal strips. We've had some barriers there. But for us as a company, for bringing competency into our labor and delivery nurse up to what we consider to be a high level, the A1 program was the first program that we were able to demonstrate a true business case on why we would want to make an investment in non-productive time to train nurses to read that rhythm strip correctly, to have a common language, to talk to one another about interpretation of those strips, and just overall to improve the quality of care. We next moved into what has been mentioned, the value-based performance era of the Affordable Care Act, where we now have at risk 2% of that $16.6 billion, that if we don't deliver on the value contribution to core measures, perinatal core measures as an example, we could be at risk at losing 2% of our revenue, which in any one quarter could be $35 to $40 million that we've earned, but we're just not going to get it because we didn't do well enough on the core measures. Some of the things that we've implemented that have brought some really positive results in our company. 3 years ago, we implemented an elective delivery policy, the less than 39 weeks, and we went from a rate of 11% to just the first quarter of this year down to 2.4% across those 60 hospitals, which is a pretty dramatic drop over just a 36-month period of time. We have implemented the trial of labor, or the TOLOC policy, and we've had great success there as well. Our C-section rate is down below 27%. And the infant feeding policy, which is essentially our breastfeeding policy, is a carbon copy of the 10 steps and everything that you've talked about today in order to get the moms set up to be successful at embracing and adopting breastfeeding and sticking to it for the amount of time that they're with us. And then, of course, the public reporting of the new core measures for the perinatal PCO1 through PCO5A, which I'll show you some results here in just a minute. In 2014, when we became a much larger company, we decided to embrace the concept of shared governance in an interdisciplinary fashion. And as a large company trying to manage 80 acute care hospitals and 36,000 physicians and 28,000 registered nurses and, all those millions of patient encounters, we decided to allow all of our professional specialties to operate at an interdisciplinary shared governance council level, and we stood up a Women and Infants Council. My director of Perinatal Services is the nurse chair, and there is an OB physician chair, and they are a dyad equal pair. And together with 2 members from each one of our markets and region, a group of 20 people decide the entire evidence-based practice around our company's delivery of women and infants and children's practice. So it's a system-wide interdisciplinary council. If there's anything I identify as an opportunity for improvement in care or something, capital equipment we need to spend millions of dollars to acquire, this is the group that I would go to present to ask them for a recommendation or to prepare an evidence-based practice business case for it, or in fact to write a policy to recommend to us as a company to ask all of our hospitals to follow. So for breastfeeding, we've had a lot of company support for breastfeeding. First of all, for new moms, to encourage them as soon as we become introduced to them, to introduce to them the opportunity and the reasons why breastfeeding can make a difference for them and for their baby. Our shortcoming there is many of our moms, and you've heard the statistics, 50% are Medicaid or more, and I'm going to show you a slide in a minute that we're in some culturally sensitive markets in the United States where it's in the 70% is Medicaid. I have less than 48 hours with those new moms to make a great first impression, give them a whole lot of education about why this is important, and more importantly, to get that skin to skin and to get that first latch going. And then they're gone in 48 hours, and I probably will never see them again until they come back with another baby. So in my business, unless we own the obstetric service, unless we own that physician group, and that perinatal, that mom comes to us prenatally where I can start an early relationship with her and the family, I have less than 48 hours to make an impact and to make a difference in what we're trying to achieve. But I think as healthcare changes and as we become more accountable for managing that risk, both with our managed care partners as well as those ACOs we own, that we are going to have an opportunity to touch these people in the community as soon as we learn that they're about to come to our hospital to receive a service. We try as much as we can in the communities that we operate in to be community friendly and to support any kind of an activity in the perinatal education area to get moms who will be coming to our hospitals to take our classes. I consider to be a very employee-friendly company. In our corporate office in Dallas, Texas, we have a very nice lounge that is especially for moms who are breastfeeding or who are going to have a child brought into the corporate office by a family member in order to be actively breastfed right there at the workplace. We also emulate that in our local hospitals. We do leave that policy up to the hospital on how they'll relieve that nurse, how they'll cover that nurse's patient care assignment duties or any other kind of an employee. But I think we're a very friendly employer in this space of supporting our employees to continue with their breastfeeding. As the chief nurse officer for the company, I can tell you that the last thing that I want to do is have a registered nurse who is very competent at what they do, valued by the hospital for their competency, for their tenure, for their engagement with us, only for me to say, I can't afford to give you 15 or 20 minutes to go breastfeed, and then to see that nurse leave. Because when that nurse leaves, on average, it costs me $75,000 to put an ad in the paper, find that nurse, get that nurse in on the first day, and then spend anywhere from 8 to 12 weeks orienting them to get to know our hospital. So the last thing I want to do is lose a highly skilled clinician, a registered nurse, a pharmacist, a therapist, because we don't have a breast-friendly policy in our hospital. So I do drive that as an expectation for our benefit plan that we continue to provide that. I absolutely support the baby-friendly designations. My director of perinatal and the manager oversee our hospitals actually being coached on how to get to that designation. I find a lot more of the barriers are not so much about us saying, yes, we support it. Here's the check to go get it. Now go get it. It's more about some obstacles involving clinical practice that are local and may be driven by cultural sensitivity of the physician or of the population where we want to have the baby-friendly designation. Today we have 2 that are officially designated, and we're waiting on our 3rd one to be designated. It's very tough to get, and it's even tougher to keep, but we do support it. We also support a new program called Golden Drops. Are you familiar with Golden Drops? Golden Drops is a program that collects the first breastfeeding milk and then brings it in for the mom to give it to maybe the NICU or the PICU, the neonate baby. And we have little magnetic golden drops that are on the mother's door frame so that everyone on that department knows that that's a Golden Drops baby and that there's some special milk someplace for them. And then we also have human milk donation centers, and we actually have milk donation banks for our hospitals to participate in. In August of 2015, we're going to join the Breastfeeding Month awareness campaign, and all of our 60 hospitals will actively have a visual and an educational campaign for our staff, for any public members walking through the building, and to any OB clinics that we can possibly infiltrate and get literature placed in their lobbies. We want to have a huge awareness this year about breastfeeding, and our company supporting that, and then next year think about maybe partnering with our local health departments or our WIC associations so that we can create a network of interest or an affinity group of bringing more awareness in a particular community about the benefits of breast milk. I had lunch today, and I was asking a couple people at the team, what could I possibly do that's kind of interesting and exciting to bring awareness to this first campaign in August. And one of the individuals sitting at the table, who's a pediatric anesthesiologist, I don't think I see her in the room right now. Oh, there you are. I said, what could I possibly do? And she said, T-shirt. I said, I love T-shirts. What would I put on that T-shirt? And she gave it to me. Keep calm, I'm breastfeeding. So I am going to go back and buy about 28,000 of those T-shirts and just give them away to any mom that breastfeed or any employee of ours that's breastfeeding. But I want to bring a visualization and an awareness to it to give you an idea that the impact someone in a position like I have over a corporation this large where you operate 80 hospitals. I came across about 9 months ago something I didn't know, and I used to be a pediatric cardiothoracic nurse, and I just never connected these dots before. But we acquired the Detroit Medical Center about 18 months ago, and one of the big issues in Detroit in the summer is children virtually get no nutritious meals during the summer because school is out. So in our Detroit hospitals, DMC Level 1 Trauma Center produces more emergency room trained physicians in the United States than anybody. And then our Children's Hospital of Michigan, which sits next door, which does all high-end kinds of pediatric care, sees all sorts of malnutrition children through the summer. So one of the nurses up there, in a shared governance philosophy, created a cereal drive about 3 or 4 years ago at that one hospital and raised a few thousand boxes of cereal. When I met this nurse on our introductory town hall meetings when we acquired that particular hospital, I walked away with such an impression of this is something that I could literally just put a campaign behind it, write an email, put a call to action, ask 28,000 registered nurses, each of you bring in 10 boxes of cereal. We're only going to do this for 7 business days, and if you don't want to go buy cereal, I'll take your money. And May 29th of this year to June 5th of this year, we raised just for cereal, 2.6 million servings of food and $80,000 in cash in a very short amount of time. If I can do that for children's malnutrition during the summer and host a cereal drive and put my name, my brand on it, and put some glossy posters out and hold a few conference calls. Can you imagine if I can come up with the right concept for breastfeeding in 60 hospitals that deliver 500 babies a month, the impact we might possibly have on bringing breastfeeding awareness, and more importantly, keeping the mom breastfeeding after that 48 hours of intervention time I have. One of the big hits for us has been the implementation of electronic medical record. I think there's been a few topics flown around here today that I've written myself little notes about where I could leverage our electronic medical record between the inpatient and the outpatient environment to bring more transparency in giving the obstetrician information we know about the patient, and then when the patient's discharged, giving them a discharge summary that this is a breastfeeding mom conducting a discharge phone call. But one of the risks that I did not see coming that the EMR has helped me drop to 0 events. Before we became an EMR system, all 80 hospitals have the same EMR. Before we became an EMR hospital, we were having breast milk medication events, meaning 3 or 4 moms have donated their breast milk. It's in a bottle. It's got their name. I go grab a bottle for patient A, and I give it to patient C. That's a medication event in my world. And if this is an HIV mom, I have a major malpractice suit on my hands because I'm the nurse. And okay. So we started barcoding our human milk, breast milk. And we went from X number of events. I've had none in 3 years. So I've made it a safer environment by leveraging technology to ensure that I can almost take away any possible human error of giving the wrong milk to the wrong baby. So I just wanted to throw in the importance of in a system like where I'm working and trying to avoid risk, that the EMR is beginning to pay off in some ways I really had not thought of before. And then some of the issues we have with adoption, at least in the markets where I operate, are getting perinatal education. It's not me offering it, it's getting active participation by the mom and some other support person to attend the perinatal classes. And then there is, in some major markets where we operate, some cultural sensitivity and adoption issues. And I went and grabbed, just to demonstrate the growth in the Hispanic population in the markets where we operate our hospitals. This came off of the Pew's website, giving a color-coded map of the saturation of Hispanics in the United States. And those red circles are all of the markets where we own hospitals, at least 3 or 4 in that city. And you can imagine the Hispanic population is one of those populations where if we have an opportunity to spend some extra time with them, it's one of them that we're going to put at the top of the list to give them some extra education. Sometimes it's health literacy, sometimes it's a language barrier, but sometimes it is cultural sensitivity and adoption to breastfeeding. But because we own most of our hospitals in these red circle locations, cultural sensitivity, becoming aware of that, teaching that to hospital staff, getting nurses trained in how to deal with it successfully is a major initiative of mine and of my department. And I just wanted to pull out that it just happens to be in every location that we operate in outside of Boston. Give you an idea of this value-based performance. As a acute care hospital operator, we are at risk, as I said before, for 2% of our reimbursement, at risk to be lost if we don't perform at a certain level in these quality outcomes. And I just grabbed the 2 here that are reflective of what we're talking about today. And when we look at the perinatal core measure 05 for exclusive breast milk feeding, we ended in 2014 at a 41% rate, and this year, the first quarter, we're up just 43%, just a few percent. But we are growing and we're doing better. If the nation is at 44 or 45, I'm feeling better that we're making progress here. Probably not at the pace I'd like to make it, but we are making progress. And then number 05A, which has been the real challenge for us, exclusive breast milk feeding, considering the mother's initial feeding plan. Mom comes in, she's in labor, I go through an initial nursing assessment, I ask her about her preferences for feeding the baby. She tells me, I want to breastfeed the baby. I check the box, we're good to go, we go have the baby. 4 or 5 hours later, we've done skin to skin, and we've done first latch, and we've taken her and the baby back to the room. Hour later, she hits the call bell, I go in, I'm too tired, I can't do this, take the baby to the nursery. And even though we try and diffuse that and turn that around and maybe give her a 1 or 2 hour rest and bring that baby back, they have been changing their minds and going to formula. We decided to hit this one hard last year and drive some performance in our nursing staff to really be out there, be at the bedside, and in that first interaction really nail the importance of why we should stick with it. You're going to be tired. You're going to get a C-section. I'm going to be here to support you. You're going to be here a day extra. We're going to have some time. So we gave our nurses some extra education, some what's in it for them, what's in it for the mom, and asked them to go out and do the best they could. And they started at 63.8% last year, and I think we've seen a pretty nice bump here, almost 5% in the first quarter of this year. So I'm excited that I think we're probably going to do a little bit better job of getting that initial plan documented and getting the mom to stick with it. So for me as a system chief nurse officer, I want to continue to drive changes system-wide, not individual hospitals, but system-wide for excellence in the care of women and infants. I want to partner more with our physician offices as most as I can. We don't own them all. We own very few OB programs, in fact. But of those that we do own, we do have a little bit more leverage. And the ones we don't own, we just need to do a lot of education, really, with the person managing the front desk and allowing us to put pamphlets and posters out there. I want to continue to support the perinatal standards of care, introducing breastfeeding and my Breastfeeding Awareness Month in August, address perinatal education support at the hospital level, whether that be for the staff or the mom and the support person, supporting our board-certified lactation consultants in our hospitals. They're few and far between. I'm also finding newly licensed nurses are not aspiring to work in OB. They see it as a very high-risk area, and I'm having a hard time getting newly licensed nurses, grad nurses, to go into OB and to spend 3 or 4 years and become an expert in that patient population, and then for some of them to go on and be lactation consultants. I want to continue to support the baby-friendly designations and drive anything I can in that area to getting it as well as keeping it. And then going back to our managed care partners and negotiating some rate preferences based on that designation and our outcomes. And then finally, support excellence in nursing practice related to women and children around the adoption of this breastfeeding. So with that, thank you very much. And again, I have enjoyed being here with you today.
Now, let's have a question period for both of you. And those of you who were watching the schedule assiduously will notice there was a break. There isn't anymore. So for those of you who need a break, the same will apply and we'll have 2 discussants at once. So
Do we have another?
you okay? You each
Yeah,
have a
we're good.
glass of
We're
water
good.
or
No, we're
something?
good. We're good. We're nurses. We can handle this, right?
So I'm Rachel Abramson from Health Connect One. The last 3 presentations were fantastic, and as a nurse also, I'm really pleased to be in the presence of such great nursing leadership. I'm interested in your Medicaid lives, and particularly around breastfeeding, because their risks are so high, the disparities are so great, and there are costs attached to all of that. And I would suggest to your companies that not only is the need for breastfeeding support greater, perhaps, than for other populations, but I would hope that you would consider the possibility of using breastfeeding peer counselors and perhaps community-based doulas. As a postpartum nurse years ago, I became very aware of the limitations of my abilities to influence, particularly, sometimes breastfeeding initiation, but particularly breastfeeding duration and exclusivity. Those are really functions that are often best provided by a community provider, and therefore someone who is not necessarily licensed, and the credentialing is different. But as Chris mentioned, if we're thinking more about ACOs and long-term care of these lives, and also about the medical team or the healthcare team, rather than reimbursement by individual practitioners. In my 3 decades of experience, breastfeeding peer counselors and community-based doulas, all of them community health workers, and CMS says that they are, states can choose to have non-licensed personnel reimbursed. They achieve exemplary outcomes with low-income populations in communities of color with young mothers. So I would really hope that you would consider incorporating that into your plans and programs.
Thank you.
We actually do allow doulas in our hospitals. We have a credentialing process. It's not a licensing, but it is a credentialing process. What we do find is, even though we allow that, we don't find its adoption is that penetratable across all of the markets. So we'll have 1 or 2, 3, 4 hospitals that are successful at it, but we do have an open door policy to that. In fact, we really, in the OB world, have been very open to any, I would say, disruption, in the positive disruptions on how the mom wants to have that experience, up to including the other program that I support across the company with fairly strict credentialing on our nurse midwives and in education of our nursing staff. And the equipment is, we do a fair number of water births. So we're pretty liberal in letting the mom make that decision on how that experience, they want to have that at the hospital, particularly if we've got a relationship with them before the actual time of birth. So we have a big nurse midwife program. We do allow the doulas. And then in the case where the opportunity for water births came up, we embraced that as well.
Hi, I'm Paula Shrek. I'm a pediatrician from Detroit, Michigan. I really loved the presentations. I'm very inspired by your leadership in these very large health systems. I work in a health system that is a ministry that is part of Ascension. And we recently took 4 of the Ascension hospitals in the Detroit metropolitan area baby friendly. And were then asked to present at one of these governance councils for Ascension. And we were talking about moving Ascension forward, adapting baby friendly. And I'm wondering what you see as a barrier to like a collaborative at your system level for baby friendly, because we've had some barriers to our health system moving forward with that.
Yeah. For us, it's been the director of perinatal that works for me is an absolute advocate for it, and she knows everybody at the nurse leadership level, and she's actually trained every one of those labor and delivery nurses on A1. So she knows everybody at the bedside on a first name basis, and they're oftentimes swapping pictures of their kids back and forth. She's worked for us for 12 years. When I send her out to talk about a hospital becoming baby friendly, the biggest issue is getting the formula out of the building. And whether or not it's in a hospital where the patient population that's driving that service line is going to go for that. And then the third one is the physician's support to stick with a no formula organization. If we can get to the community education, and I can get in front of that mom before the time of birth sooner than I'm doing now, and that's limited because, the OB guy isn't sending them to our perinatal or some other reason. If I could get to that mom sooner, I think through perinatal education, even if it was 1 or 2 classes, I'd probably get a game up on dropping the formula mantra and accepting the breastfeeding. But I find the hardest thing is getting the formula out of the building. And quite frankly, there are some patients who don't want to hear about breastfeeding. They want the free formula. They don't want to listen to the benefits of it. So it's a community, just like, if you're diabetic, don't drink, don't eat sugar. If you're obese, lose weight. I mean, all the things we've talked about today, all these preventive chronic illnesses today. This is just another one of education of the lay people, which could be health literacy again. But
Well, one of, I'm in Detroit, where Hutzel Hospital, one of the 10 hospitals are, and we have over 80% breastfeeding rate at our hospital. So, one of the things that we do in the Academy of Breastfeeding Medicine is go out and say, change is possible, baby-friendly is possible no matter where you are. So I think a system support would mean a lot.
I'll add one more thing that I supported our company that I'm beginning to see a lot of groundswell with, and I'm going to be meeting with the top 5 payers in the United States to actually talk to them about it. I find that I am far better off when I have a magnet hospital or Pathways to Excellence, which is the Baby Magnet Award. And Harper Hutzel was a Pathways to Excellence, and they've applied for Magnet.
Yes.
And Detroit Receiving was Magnet. I can tell you in the other 7 Magnet hospitals we own, baby friendly's a walk. I mean, I can get it done immediately because it has a culture for it. Usually the physicians are behind that kind of a nursing excellence program. And I can take a Detroit Receiving Hospital or a Children's Hospital in Michigan and go visit her at Anthem and get probably 1 or 2% more on my payment. In fact, I just did that as the System Chief Nurse Officer for Tenet. I visited one of our top 5 payers that covers us in every state we operate in and asked them for 1.5% if I put a program in the ED that looked at chronic pain management. And I'm about to do that with behavioral health issues. Behavioral health issues in America's EDs are one of the biggest crises occurring right now that the onion just hasn't been peeled on yet. But, if you can get these great programs certified, designated, produce some outcomes, the population risk management information, the medical economics, and then go visit with our payers, whether it's government or private, you can get some support. And then it's just, you kind of make it, you tell the hospital executives you need baby friendly or you may be losing your maternity business, which to me, I don't make money on maternity. I make money on, unfortunately, the NICU admission, and if the child needs surgery or if the family just falls in love with the hospital and by word of mouth brings other people in the community to us.
Right.
So.
Right.
Great, thank you.
It's really interesting and talking about we making money. So the insurance company is going to make money if mom has a normal spontaneous vaginal delivery, stays for 2 days, breastfeeds her child, and goes home with her baby, right?
That's a trifecta.
My name is Isadora here. I used to work for the Maternal and Child Health Bureau in the U.S. Department of Health, and Human Services. I'm retired now and working as an individual consultant, and I really support your emphasis on baby friendly. But I listened very carefully to what you had said. I shouldn't say but, and I was interested in the little vignette you gave about the mom who puts the baby to the breast the first time, and then in the middle of the night she says, look, I'm too tired, I can't do this. Mm-hmm. And how vital it is to have an intervention at that point. Well, having said all of that, I am most interested in step 10 of baby friendly. Because as you also said, you have 48 hours, and that's all. But at 48 hours, one is still at the very beginning of the whole breastfeeding process. And what happens when mom goes home with baby, I think, is really critical for the continuation of breastfeeding. Because as important as the initiation is, if it only lasts 48 hours or 76 hours, you know, you haven't really won that battle. Mm-hmm. So I'm particularly interested, I know Rachel raised the issue of doulas and community health workers, but I wondered if you use any other strategies on linking that mom to community resources, whether in her own family or more broadly in the community.
Mm-hmm. Mm-hmm. Yeah, if the mom has a managed care payer, obviously our case management department will contact, for example, Anthem and try and get them connected to their program or to Humana's program that was mentioned earlier. If it's a Medicaid baby and there is some community service or support system out there, traditionally our nursing staff is the one that will give the education, give a pamphlet, probably don't make a phone call on behalf of the patient. I'm kind of interested to see in the electronic medical world with the patient portal, if the mom would sign up for the patient portal, then we would have permission to push that electronically to a community service that she may receive a benefit from. But the one thing I can do in a high-risk mom where the nursing staff believes there needs to be a call of encouragement is to ask a registered nurse, preferably the one that discharged that mom and baby, to make a phone call at 48, 72, and 1 week out. That costs me absolutely nothing to do. But I'll tell you where the world is going. The word millennial's been dropped already today. Phone calls are history. If I can send a computerized voice message to a mom automatically off of that Cerner EMR at 48, 72, 96, and 5 days, then I've taken the human factor and my labor cost out of the equation. It becomes automatic at that time. If I can get some kind of an engagement with the mom at that point, I would do that electronically. It's no risk for me. It can only be a benefit. Mm-hmm. But it's just getting that set up and getting it started and done. Mm-hmm. I believe in community health workers. In fact, 2 years ago, we got a fairly sizable grant from the United Way to handle heart failure readmissions in our hospitals, and we are now down below the national norm on that for all 80 because we've adopted community health workers, which are high school educated individuals who come from the same culture, the same neighborhood, speak the same language, and often know that person on a first-name basis. Who better to handle that relationship of living in the norm or living in their world? So we do embrace that. So.
Let me just follow up on that. We also see that in some of our states, if a woman delivers, she's entitled to one home health visit after that delivery. And what we see is that you're absolutely right. Well after, that discharged from the hospital is when the milk comes in.
Right,
And when mom is exhausted, what better opportunity than to send someone in to mom's home where she's sitting in her chair, in her environment,
Exactly.
and then you're teaching her how to make that transition, and you have that personal touch. And so to my point, when we look out at different states and we see best practices, that is one of the best practices where the state would say to their managed care companies, this is something that we would like for you to provide as a benefit.
Yeah.
Yeah.
Thank you.
One more question.
I was just going to offer the idea of donor human milk as a bridge. Certainly the Humana products are relatively reasonably priced, and I think if in that scenario where you had a mom who needed a break, one feeding, that was donor milk, that would encourage her to continue and really emphasize the importance of breastfeeding, might just keep them in tow.
Yeah, we do support that. We support the donor milk program. We support with our GPO the acquisition and purchase of human milk if we need to acquire it. We also allow moms who have had newborns that go to the NICU for whatever amount of time to come into the hospital 24/7, 360, however long, and actually come to the room, pump the breast milk, or feed the baby, pump and give us a few bottles, or more importantly, just feed the baby right there. And we consider that the way to provide excellent care to that baby and for that mom and family, and to carry them through whatever crisis they have with that NICU admission.
Comment?
Thank you. That's great. Absolutely agree. Thank you.
So much.